Ma'am, Chetan here, ma'am. Yeah. Good afternoon, everyone. Welcome to today's Indians program on geriatric psychiatry. Today we have with us Dr. Thomas Gregor Issac, who has done his MD and PhD from NIMHANS, who is currently doing his DM in geriatric psychiatry at NIMHANS. Today's session is on dementia, its approach and diagnosis. We also have with us Professor Dr. Srikala Bharath ma'am, who will be chairing this session. And also we have Professor Matthew Varghese sir, who is also present in this session. So welcome you all. The session is also live in our YouTube channel, NIMHANS Indians. So over to you, ma'am.
Thank you, Chetan. Good afternoon, everybody, whoever is in the CME program of NIMHANS Indian. It's a pleasure to be back in the academic circle of NIMHANS, especially geriatric psychiatry. Today we have a very important session which is on dementia. I think with the Alzheimer's Day on 21st of September, and again, the Mental Health Day and the Elders Day, all being in a series and from the last month, it's very, very relevant that we talk about dementia, one of the most important and pressing problems that we face in India, considering the fact that the number of elderly and the probable candidates for dementia, especially both Alzheimer's dementia and vascular dementia, is going to be on the rise in the next 1 or 2 decades. And Thomas would be talking about how it increases exponentially. And he would also talk about the way we need to look at when we think about dementia. Everybody thinks about only Alzheimer's dementia, and many people have this confusion, what is Alzheimer's and what is dementia? So I think he's going to give you an overview of dementia. And since this is an academic program, I think he would definitely talk about the approach, the investigations, what are the red flags, and what are the relevance, what research has been able to actually go forward, and how much is it relevant in diagnosing and also in the treatment of dementia. Over to you, Thomas.
Yeah, thank you, madam, for the nice. So I would be talking about dementia and how to approach and diagnose dementia. So the outline of my talk would be about definition, the epidemiology, what are the questions to be asked if a patient comes with cognitive decline, the etiology, and what are the difference between cortical and subcortical dementias, are there any reversible dementias, and or only neurodegenerative dementias that we have heard of. How about the diagnostic approach, wherein we look into the basic questions we ask in history, the examination, both general physical examination, the mental status examination, and specific examination for cognitive assessments, the red flags, and finally a few case vignettes for us to have a basic understanding. So dementia, the term is originated from the Latin word demens, which states out of one's mind. So it's a disease with acquired deterioration in cognitive or intellectual abilities without impairment of consciousness that impairs the successful performance of activities of daily living. So cognitive impairment represents a decline from the previous level of function. That is the most important tenet. And episodic memory is the ability to recall events specific to time and place, is a cognitive function which is most commonly lost in dementias. In addition to memory, dementia can affect not only the memory aspect that we have heard of, but most commonly it can also affect other domains like language, visuospatial, praxis, calculation, judgment, and problem-solving abilities. So the ICD-10, we all know, says that dementia is a syndrome due to disease of the brain, usually of chronic or progressive nature, in which there is a disturbance of multiple higher cortical functions, which include memory, thinking capacity, language, comprehension, calculation, learning, orientation, and judgment. The DSM actually brings about a new terminology into limelight, and in 2013, the 5th edition of DSM actually talks about major neurocognitive disorder, which replaces the term of dementia, and minor neurocognitive disorder, which is akin to the MCI or the mild cognitive impairment. So the DSM-5 says that there should be an evidence of significant cognitive decline from a previous level of performance in one or more areas of the following cognitive domains. So memory is not always required, but if there is a deterioration in complex attention, executive function, language, perceptual motor, or social cognition, and learning and memory, then it is significant to call it major neurocognitive disorder. There should be also a concern of the individual, a knowledgeable informant or the clinician that there has been a significant decline in cognitive function. And there should be an objective evidence, that is substantial impairment in cognitive performance, documented by standardized neuropsychological testing, or in the absence of the same, by another quantified clinical assessment. Also, the cognitive deficit should interfere with independence in everyday activities. The cognitive deficits do not occur exclusively in the context of a delirium, and the cognitive deficits are not better explained by another mental disorder. So this criteria is very much important in understanding the recent aspects with respect to dementia. Now coming to epidemiology. So as age increases, the incidence as well as prevalence of dementia increases. So the incidence is said to be 5 to 8% of persons aged 60 to 70 years. But there has been recent studies which has been estimated that the numbers are projected to reach 82 million by the year 2030 and 152 million by 2050. It also means that more than 85 years of age, it is a probability that at least 1 in 4 patients can have features of cognitive decline amounting to dementia. So what is the most common form of dementia is another question. So Alzheimer's dementia continues to be the most common type of dementia all across the ages. Even if it is a late onset dementia, it is the most common dementia is Alzheimer's dementia. Even if it's an early onset dementia, that is dementia defined as age less than 65 years of age, at that time also the most common is Alzheimer's dementia. Now, what are the specific questions we ask when a patient comes with features of cognitive decline? We have to think of whether is it dementia or a neurocognitive disorder, or is it a condition which is a mimic of dementia, or we call as a dementia mimic, which looks like dementia and which actually resembles dementia, but is not exactly a degenerative dementia. Is the condition treatable or partially treatable, which is another important tenet. So we know that dementias may not be curable, but do they have a burden which is caused due to a partially treatable or reversible condition? And finally, what is the specific neurodegenerative condition underlying the same? So these are the questions we have to keep in mind. So dementia has now become an umbrella term, and it encompasses all these types of dementia. I have told, based on the maximum number, it is most common is the Alzheimer's dementia, both early onset and late onset. It is a common form. Then comes vascular dementia, especially in elderly, which is due to vascular risk factors, diabetes, hypertension, smoking, etc., and due to arteriosclerosis of the vessels. Then Lewy body dementia, frontotemporal lobe dementias, and there are other dementias due to multiple other secondary causes. Now coming to etiology, it ranges from a whole spectrum of neurodegenerative, vascular due to multiple strokes, neurological due to demyelinating disorders, hereditary disorders, Down syndrome, endocrine disorders, nutritional, infectious, metabolic, traumatic and diffuse brain damage due to head injury, and it can be due to toxic agents like especially substances like alcohol. So aluminium is one such metal which is implicated. Can be due to chronic use of anticholinergic drugs. Psychiatric manifestations due to depression, schizophrenia, conversion disorder can also resemble features of dementia, and miscellaneous causes like autoimmune causes, vasculitis, and some genetic causes. Now coming to the difference between cortical and subcortical dementia. Cortical dementia is when the cortex is actually actively involved, and subcortical is when the subcortical structures, which include the basal ganglia, striatum, which are getting involved. So in cortical, the major changes because of the gray matter affection, the major changes are there in memory, language, perceptual deficits, and apraxia. Whereas subcortical, the symptoms will be mainly because of the subcortical involvement of the frontal lobe, white matter changes can happen and can result in behavioral changes, significant executive dysfunction, motor slowing, but lesser severe changes in memory. Also in cortical dementias, there can be lack of extrapyramidal features. Whereas subcortical, because the basal ganglia is involved, there can be presence of extrapyramidal features. In cortical, the areas affected obviously will be the frontal lobe, the temporal lobe, the parietal lobe, and especially the medial temporal lobe, wherein the important structure of hippocampus is present, is affected. Whereas in subcortical dementias, mainly the thalamus, striata midbrain, and striata frontal projections are affected. The examples of cortical dementias are Alzheimer's dementia, dementia with Lewy body, frontotemporal dementia, and vascular dementia. Whereas subcortical dementias include Parkinson's disease, dementia, progressive supranuclear palsy, and normal pressure hydrocephalus, Huntington's disease, CJD, etc. CJD also affects the cortex as well. And there can be dementia pugilistica, which is due to multiple rupture of the small arteries due to recurrent head trauma. Now, degenerative dementia, I have already told the difference between cortical and subcortical, but clinically, there are some points which can help us to differentiate. So in cortical kind of dementias, usually the patient gives quick but wrong answers to questions. And subcortical, the processing speed is actually very increased. So they give right answers, but after a long reaction time. Cortical dementias, also the patient can have behavioral problems. There will be more of euphoria, and poor insight will be there, like in frontotemporal dementia. In subcortical, because the anterior, this executive syndrome is there, they will have more of apathy and depression. Also, in degenerative dementias of cortical nature, they can have agnosias, aphasias, apraxia, seizures, and myoclonus, which is often not seen in subcortical type of dementias. And the extrapyramidal features are seen very late in cortical dementias, especially in the moderate to severe stages, whereas in subcortical dementia, it will be manifesting, especially as rigidity and other extrapyramidal symptoms. The neurotransmitters implicated are also slightly different. In cortical dementias, there is deficiency of the acetylcholine, whereas in subcortical, it is mainly the dopamine as well as the GABA, which is implicated. Now, coming to a concept of mixed dementias. So there were a lot of controversies with respect to this particular term, and it has been found that actually there could not be any dementia in isolation, and all dementias could be mixed dementias. However, the recent concept is that Alzheimer's dementia, when it coexists with a vascular dementia, it is to be called as a mixed dementia rather than combination of other patterns of dementia. So this is one important aspect. Now, this is still remaining a controversial area. However, when both pathologies of Alzheimer and vascular coexist, we actually now call it as mixed dementias. Now, reversible dementias can be memorized by this acronym, dementia itself, wherein D stands for delirium, E for emotions, mainly features as of depression as well as endocrine disease, M for metabolic disturbance, E for eye and ear impairments, N for nutritional disorders and NPH, T for tumors, toxicity, and trauma, and I for infections, and A for alcohol and arteriosclerosis. This would give an easy tool for memorizing the causes of reversible dementia. Now, irreversible dementias are mainly neurodegenerative conditions, and they will include Alzheimer's dementia, vascular dementia, Lewy body dementia, Parkinson's disease dementia, frontotemporal dementia, Huntington's disease, CJD, and leukoencephalopathies, some of which we will be discussing in the coming few minutes. Now, how do we approach a case of dementia? So if a patient comes with a cognitive impairment, and we have to see whether there's a deterioration from a previously higher level. If not, it could be having features of an IDD or a mental retardation. And if there is a deterioration, we should assess for the consciousness. If it is altered, then we have to consider for features such as delirium. There is a disorder of attention, focusing, and consciousness, fluctuating sensorium. We should consider more of delirium. But if the consciousness is not altered, there is deterioration from a previously higher level, and multiple cognitive functions are involved, then we have to see whether there is a serious interference with the daily activities. If there is a deficiency or deficit in the instrumental activities of daily living as well as the activities of daily living, it is likely that the patient is having dementia. However, even though the patient is having a deterioration, consciousness is retained, multiple cognitive functions are involved, but still the patient is able to be independent for activities of daily living and instrumental activities of daily living. He is having a minor neurocognitive disorder or mild cognitive impairment called as MCI. So complaints of cognitive decline, if there is normal cognitive functioning, that is evidence of normal aging. If there is impairment of cognitive function, you have to look for activities of daily living. If it is impaired, consider dementia. If not, consider MCI, depression, or maybe a part of normal aging itself, but we have to do formal assessments for that. Now, how to diagnose a case of dementia? There should be a focused history apart from the routine questions in presenting complaints that we ask. There should be a proper symptom analysis. There should be a focused physical examination, especially look at various indicators in the body, which could suggest some reversible causes of dementia. A cognitive and neuropsychiatric examination is actually mandatory, and lab evaluation is actually helpful, but 90% of the information is provided by the history itself. Now, there are some things to differentiate because this is slightly kind of a flexible area. We have to differentiate between healthy aging, mild cognitive impairment, late life functional psychiatric disorders like pseudodementia, delirium, and static encephalopathies. So these are the things we should keep in our mind when we approach a patient with cognitive decline. So this is one table which enumerates the difference between depression, delirium, and dementia. And the important aspect is the onset. Depression takes weeks to months, delirium in hours to days, and dementia from months to years. And the mood, in depression definitely you can get a low mood, and delirium there can be a fluctuation in the mood and affect, and dementia also there could be a fluctuation. The course is acute for delirium, whereas chronic for both depression and dementia. And about the insight. So the depressive patients usually are concerned about the memory impairment, and they give more of I don't know answers. Whereas patient with dementia may be unaware of the cognitive deficits, and he gives maybe quick and wrong answers. And patients with delirium, based on the fluctuation of the sensorium, they may be responding to responding with to the questions which are asked. And activities of daily living may be affected in case of dementia, like we have already discussed. In depression, it will be mainly neglect of the basic self-care. Delirium, it also depends on the sensorium at that particular point of time. And in instrumental activities of daily living also, it is definitely impaired as the dementia progresses. But in depression, it would be usually retained, and in delirium, it can be impaired if there is actually issues with sensorium. Now coming to the spectrum, which we start with the benign forgetfulness of aging, which is a normal phenomena. Now, what are the typical features? Here, as the elderly would have failure to remember unimportant daily experiences, something which is out of ordinary, which is not very important, very subtle, he may fail to remember. That could be due to the attentional deficit, and it is not considered pathological. The ADLs would be quite all right. They would be independent for both instrumental activities as well as activities of daily living. And they have a difficulty in multitasking. So as age advances, the person usually can attend to one stimuli at a time and cannot attend to multiple stimuli at a time. And increased situational anxiety. So based on there could be situational anxiety which would happen, and would be a cautious approach, telling that I may forget, but usually he or she would be able to recollect. And he is able to understand logically correlated events. So these are some of the important aspects of benign forgetfulness of aging, also known as the tip of tongue phenomena. They have difficulty in naming, but after some time they are able to recollect and tell the name. Now coming to MCI, which is the stage which actually is a flux between the benign forgetfulness of aging and the dementia. So in MCI, the cognitive changes are of concern to the individual and or to the family, and one or more cognitive domains are impaired significantly. But as we have discussed, there would be preserved activities of daily living and instrumental activity. So the patient is actually independent. However, he has ability to know that he is not as efficient like before, and he has difficulty when in standard neuropsychological test, the deficits would be less than 2 standard deviations from that of the normal. But in dementia, it will be more than 2 standard deviations of the normal. And dementia is further into different classified into different stages: mild, moderate, and severe, based on the CDR scale also. So there is another concept which I would like to tell here is the new concept of subjective memory complaint, which is also now considered as to be a part of MCI, wherein objectively the family members or the relatives do not note any particular issue, but the patient himself feels that he is having memory complaints, and he complains about this. So it has been found that subjective memory complaint is a part of MCI, and it is also a precursor for developing into dementia. So these are some of the concepts. Now, how to take history and why it is important. I have actually given a peek into that. So we have to begin with the patient. It is important not to infantilize that person. We have to get collateral history. That is very much important in dementia, but we should not neglect the patient because it helps to build a proper rapport. And when we introduce management strategies, this would be very helpful. The motivating factor, it also becomes a good factor for actually further examination and testing. And the subjective account of concerns and problems has to be taken into account, because that will be an important clue into the behavioral and psychological symptoms associated with dementia. And the conversations will act as a tool to get more idea into the mental status and cognitive functions. So we have to start by beginning to ask, when was the last time they were absolutely okay? And what was the heralding symptom? So most of the patients and families actually will start from the point when the deficits were quite severe enough to interfere with their daily life activities. So they will not be able to give the correct onset, which is often not very clear. So in that way, we can actually link to events, life events. So like retirement. So when he got retired, before retirement, how he was, or how she was handling the house affairs. Then what happened when the husband died? Was she able to do all the rituals, or was she able to perform all the activities properly, look after the house and all that? And is there a change of house? Also can be some, these are some important life events which the patient as well as the families would remember. So this can give us a clue into the kind of life charting of the events, so that we can get the onset of the illness and also the heralding symptom, which is quite important. That is, the chronology of the problem should be addressed. Mode of onset has to be known. Progression, whether if it is slow, it is a clue that it is a degenerative dementia, likely to be an Alzheimer's kind of dementia. If it is stepwise, when the patient loses the cognitive abilities in a stepwise manner, that he will be retaining some of the abilities for some time, but again he will go down, and in a stepwise manner, it would be likely to be vascular dementia. If it is a rapid progression, maybe over a period of few months or less than a year, it could be CJD. And sometimes in frontotemporal dementias, especially when the language is lost, and the progression with fluctuations, like there are phases wherein the patient has altered sensorium, but he gets in between, he would be absolutely fine, would give a clue that it could be Lewy body dementia. And the duration of symptoms. So we can find out whether it's rapidly progressive or kind of a slowly progressive kind of illness. Now, the history of present illness, we have the patients usually have tendency to report only of the patient relatives usually to have report only of the problem behavior. They will, instead of giving an idea into the duration, the onset, and the heralding symptom, they'll be telling about the current issues which the patient may be having. So we have to contextualize the thoughts, behaviors, emotional responses, understanding, and consequences. This helps us to actually get a good history. We have to deconstruct the deficit. So what activity is there a problem with? What is the kind of error made by the patient? How does the person overcome or compensate or avoid the problem? What strategies he uses? So these are some things which can actually help us. Also, the life charting is quite important. Like in all psychiatric disorders, we have to know the onset, the progression, the sequence in which the problems arose. Because finally, end-stage dementia resembles all types of dementias end stage. So it is common. So the difference is actually in the initial part. How this progresses will give a clue into the subtype of dementia. So we have to also look into the sequence in which changes in behavior and personality occurred, the nature of changes and adaptations in the environment. So coming to cognitive impairment, we have to look for the types of cognitive impairment, whether there's a memory impairment, this is an episodic memory, immediate, recent or remote, or if there is amnesia, what type of amnesia it is. Is there aphasia, is there apraxia, is there agnosia? Aphasia mainly deficits in comprehension and fluency, it's a language deficit. Apraxia is actually when there is an inability to carry out learned motor activities despite a normal sensory, motor and cerebellar function on command. And agnosia is the failure to modality specific deficit wherein you have a failure to recognize. And impairments in executive functioning. So there is disturbance in complex attention, planning, organizing, sequencing, abstraction and all that. And impaired visuospatial functioning. So whether there is a deficit in dressing, wandering tendency, failure to come back home, difficulty in copying or making pictures, all that are quite important. Now coming to functional impairment, each of the cognitive deficits can result in significant impairment in functioning, which represents a decline from the previous level of function. So we have to find out difficulties with job performance if he is still employed, difficulties in other instrumental activities like driving, shopping, housekeeping. This could help us in identifying where is the exact deficit, and sometimes the patient or particular person who is affected with dementia starts keeping notes. So there's a sudden change in he made some strategies to actually help or aid his memory. So these are some clues which give that there is likely functional impairment. And difficulties in social functioning, that is disengagement from usual activities or interests, trouble maintaining social relationship and social roles, and finally difficulty performing activities of daily living. So functional impairment has to be looked into. Behavioral disturbance, significantly apathy is something which is seen all across dementias, especially in frontotemporal dementias. You have to look for features of disinhibition, compulsivity, loss of empathy for others, and overeating like food faddism, especially preference for sweet items or preference for non-vegetarian kind of food. So which has developed all of a sudden would suggest of more of a frontotemporal type of dementia. And agitation, aggressive behavior, uncooperative behavior, and wandering, along with worsening of agitation in evening hours, which is called sundowning. And these symptoms account for substantial caregiving burden and are often triggers for moves to higher levels of care. So the cost, there has been a lot of study on the costs which are estimated in dementia, and it has been found that these symptoms, the BPSD symptoms, do increase the costs which are required for dementia care and cause a significant burden on the caregiver as well. Now we have to look into the change in personality, especially features such as newly developing disinhibition, impulsivity, making inappropriate jokes, being over familiar, disregarding social norms, loss of judgment and reasoning, and inappropriate sexual remarks or behaviors which are important to be assessed. Now, what about psychosis in dementia? So there has been a lot of research in this particular area, and it has been found that delusions are common, mainly with the common themes of theft, infidelity, and misidentification in late stages of AD. It is not seen in the early stages, only towards the late stages. In frontotemporal dementia, there is research to indicate that psychotic symptoms can precede the development of frontotemporal dementia. In late stages, about 10% of AD patients develop Capgras syndrome, that is the delusion of doubles. And visual hallucination and Capgras syndrome could be seen in as early features in Lewy body dementia. Now, mood changes. 10% of patients with dementia can have features such as major depression, and 50% of Alzheimer's patients have depressive symptoms. So depressive symptoms, emotional lability and irritability may be related to psychological reactions to the awareness of losing one's memory and anticipation of increasing functional impairment. And there can be suicidal ideation and self-harm behavior, especially people who have retained insight. So we have to be careful, especially if there is depression. We have to actively look for depression, and if needed, we have to treat that. Now, anxiety is another common symptom which is seen in dementia. About 60% of patients encounter anxiety, and usually they can exhibit catastrophic reactions when confronted with cognitive limitations. Because for a teacher or somebody who was quite active, suddenly he is not able to write or he is not able to actually issue a check. This would be actually very devastating event for him. So this can cause significant anxiety and stress for that particular person. So other important points we have to see is we have to see for any movement disorders, rule out any history of seizures, history of gait disturbance because it is also associated with normal pressure hydrocephalus, recurrent head trauma, especially if the patient is having alcoholic and has history of multiple falls. And also when history of alcohol abuse is there, you have to look for history of malnutrition and previous history of complicated withdrawal, wernicke's encephalopathy, etc. History of diet, what kind of does he take a mixed diet or pure vegetarian, history of bowel irradiation, gastric surgery, antihistamine therapy, as well as now we have to also look into many people are on ketogenic diet, which many studies are coming up with the concept that it can also affect, it can cause changes in the metabolism and increase utilization of B12, resulting in relative deficiency of B12 also. So these are some things which we have to keep in mind. And past history of hypertension and diabetes is important in vascular dementia. Also high risk behaviors, especially in when we suspect features history of HIV or syphilis. Occupational history is important, and also history of chronic drug use, especially use of sedatives and analgesics for years together, and family history of dementia, especially in the family members who had early onset of dementia. So these are some things which we have already covered. And AD usually begins with memory disturbance. Frontotemporal dementia starts with personality or language issues, followed by memory issues. And dementia with Lewy bodies, usually visual hallucination, Parkinsonian features. There is proneness to delirium, neuroleptic sensitivity, RBD. And vascular dementia, there can be history of multiple strokes. And CJD will have a rapid progression of dementia associated with motor rigidity and myoclonus. So general physical examination, we have to look into the vitals. Along with that, as of now, because of the COVID pandemic, you have to also definitely look into the oxygen saturation. Skin examination can give a clue if any nutritional deficiency. Sensory impairment is very much important to assess because that could be one of the cause which worsens the BPSD symptoms. Signs and symptoms of organ dysfunction and metabolic disorders have to be looked into. Any focal deficits like peripheral neuropathy, facial nerve palsy could give a clue into underlying stroke or a vitamin deficiency. Movement disorders, look into nutrition and hydration and any injury and deformity. Physical examination will include a detailed neurological examination to look for focal neurological deficits, extrapyramidal signs, vision and hearing, cardiac and pulmonary evaluation also has to be done. So in AD, usually the initial neurological examination normal, the motor system involvement will be late. Whereas in frontotemporal dementia, they may have features of extrapyramidal symptoms, gaze, palsy, and associated motor neuron disease. And Lewy body symptoms, usually they'll have a Parkinsonian features and associated visual hallucination and RBDs. And PSP, we know, is a Parkinson plus syndrome. They can have axial rigidity, dysphagia, and supranuclear vertical gaze deficits. And corticobasal syndrome can have features of asymmetric rigidity, the typical alien phenomena, and they can have a non-fluent affect executive dysfunction or behavioral issues. So, of the clue. Also, we have to see for hemiparesis. We have to see for any features as to of myelopathy or peripheral neuro. We have for features in elderly. We have to actually correct, see, and if there is hearing or visual loss, have to correct it. So mental status examination would include looking at the general appearance and behavior. If there is any pseudo-bulbar affect, motor activity, you have to look for utilization, behavior, perseveration, etc., especially in frontotemporal dementia. Use of language. The language can get affected. I can use stock words, rehearsed answers, and telegraphic kind of speech, which has to be looked into, and look into the insight and judgment. So these are some of the bedside tests which we can do, which are there in the Mayor perform as well. Look into the attention, memory, language, praxis, visuospatial, executive functioning, and behavior. Behavioral observation and analysis is one of the important aspects of assessment in dementia. And cognitive and neuropsychiatric examination would also, I have told the type of deficits in cognitive testing. AD, it will be more of episodic memory loss. FTD, it will be more of deficits in executive control, language functions, and Parkinson's disease or Lewy body dementia, deficits in visuospatial function. And vascular, it could be a mixture of the executive control and visuospatial deficits with significant retarded psychomotor retardation and slowing of processing speed. So some of the neuropsychological batteries, which gives a comprehensive idea, is the NIMHANS neuropsychological battery for elderly. The adenovirus cognitive examination, PGI battery, and AIMS also has come with a comprehensive neuropsychological battery and the SERAT battery. These are some of the batteries of the whole list, which are very useful, especially the NIMHANS neuropsychological battery is especially developed for elderly. And so what about the investigations? There are some mandatory tests for dementia, which include the CBC, ESR, the TSH, B12 folate, blood glucose levels, creatinine, calcium, liver functions, electrolytes, and neuroimaging. It could be CT also. There is no mandate for an MRI always. And there are optional tests, especially VDRL and HIV are optional tests, which can be done if we suspect the other causes, secondary causes of dementia. So there are now newer tests like lumbar puncture are indicated when CNS infection is there. Brain biopsy is usually considered only to diagnose vasculitis and neoplasms or unusual infections. So with this, we have covered the broad aspects of dementia. There are subtypes of dementia we can just go through. This is the Alzheimer's dementia, where the main tenet is the decline in memory and learning, and at least in some other of the 5 cognitive domains. And it should be steadily progressive, and there should not be any evidence of mixed etiology. Vascular disease, we have already gone through, is then temporarily related. It should be temporarily related to a cerebrovascular accident. Decline should be mainly in the executive functioning as well as the domain of complex attention, and there should be support by imaging evidence of significant parenchymal injury. The frontotemporal dementia is different type. The behavioral variant will have behavioral disinhibition, apathy, loss of sympathy, empathy, perseveration, stereotype behavior, hyperality, and dietary changes. The language variants, which include the logopenic variant, which is the rarest variant, and the also the semantic variant and the PPA. This primary progressive aphasia variant. You have to look into the speech production, word finding, object naming, grammar, and word comprehension, which could be affected early in the path of the illness. Parkinson's disease would occur only in the context of an established Parkinson's disease, at least 1 year of Parkinson's disease, followed by which the patient should have features of cognitive decline. And in dementia Lewy body, the cognition will be affected before other features, and they can have recurrent visual hallucinations and also spontaneous features of Parkinsonism with the onset, subsequent to development of the cognitive decline. So here, the cognitive decline precedes or is along with the Parkinsonian features. So AD is the most common type of dementia, characterized by progressive loss of cortical neurons, and there can be formation of neurotic plaques, neuritic plaques, and neurofibrillary tangles. Neurotic plaques are beta amyloid, and neurofibrillary tangles are hyperphosphorylated tau. And there will be a decrease in the cortical levels of neurotransmitters, mainly acetylcholine, and there can be a deficiency of acetylcholine, which requires the utilization of cholinesterase inhibitors. The clinical manifestation will begin with memory impairment, then followed by visuospatial. There can be unawareness of the is known as anosognosia. Cognitive can be with respect to driving all the instrumental activities. Language can be impaired later in the part of illness. Apraxia is something which can be affected. Means praxis errors can be seen. Visuospatial deficits, and in later stages they can have delusions, psychotic symptoms, which we have discussed, and end stage they can become rigid, mute, incontinent, bedridden with hyperactive dependent jerks and myoclonic jerks, and death usually results from malnutrition, secondary infection, and aspiration and pneumonia. So this is the typical kind of progression in AD. And diagnosis is mainly aided by neuroimaging, which shows predominant structures being the medial temporal and the parietal lobes getting affected. And PET shows hypometabolism in the posterior temporoparietal cortex. And there are now amyloid PET will help in assessing the density of the amyloid deposition. EEG is very non-specific. However, it can show slowing, especially in the posterior regions. And lumbar puncture will show, CSF shows low A beta 42 because it is deposited as plaques and mildly elevated tau. So this is would be seen, and treatment would be covered in the subsequent sessions, but cholinesterase inhibitors form the mainstay. So these are the MRI images, T2-weighted images, which the yellow arrows indicate the widening of the sulci, as well as in the picture on the right, it also indicates the medial temporal lobe, which has become significantly atrophic. So vascular dementia also, there are multiple terms for that, and multi-infarct dementia was one of the older terms, which consists of recurrent strokes, stepwise progression, and background history of comorbidities like hypertension, diabetes, and coronary artery disease. And MRI will show multiple areas of infarction. So this is the typical progression in vascular. So there will be a sudden fall when you get a stroke or when you get a vascular event. There will be sudden fall in the cognition. Then there would be a mild improvement once the because it's vascular resupply is re-established. Then there will be again a fall from the previous baseline. So it goes down in a stepwise manner. Whereas subcortical vascular dementia almost resembles like a AD, there will be a gradual progression, and there can be strategic single infarct dementia wherein there can be infarcts in strategic areas like the dorsal nucleus of the thalamus, or there can be a stroke in the PCA territory, which can result in what we know as significant cognitive deficits, which actually is out of proportion to the lesion which is seen in the MRI. Now, this is the imaging seen in vascular dementia. The upper picture shows a normal control, whereas in the lower picture, the B picture shows there is significant white matter hyperintensities, which is almost very much confluent kind of white matter hyperintensities, which is known as graded by the Fasekas grading. And visually, we can see that this is significantly confluent, almost amounting to Faseka grade 3 kind of white matter changes. Now, frontotemporal dementia often begins with behavioral problems. There is behavioral variant and language variant, and here the memory and visuospatial skills are spared till late and may be accompanied by motor neuron disease, which is a clue that if there is associated motor neuron disease, it's likely that the patient can have features suggestive of FTD and ALS overlap, or it could be due to, it can give a clue of what type of genetic mutation also is responsible. MRI will show focal atrophy of the frontal, insular, and temporal cortex, and there are associated protein inclusions which are there. So also the FTD is actually a tauopathy due to excessive deposition of tau. So there are other tauopathies like the PSP, which includes falls, personality changes, supranuclear vertical gaze palsy, axial dystonia, and symmetrical axial rigidity, along with the hypererect posture, dysarthria, and dysphagia. And also corticobasal syndrome, which is another tauopathy associated with atrophy in the periorlandic cortex and basal ganglia. They usually have asymmetric rigidity, dystonia, the Aryan limb phenomena, significant apraxias, pyramidal signs, node fluid aphasia, executive dysfunction. And treatment of FTD is often symptomatic. The International Psychogeriatric Association actually suggests to use selective serotonin receptor inhibitors. So these are the different patterns of atrophy which we see in frontotemporal dementias. In the A picture, we can see actually asymmetric atrophy right more than the left in the frontal and temporal lobes. And in the B picture, we can note the bulbous dilatation of the frontal horn, which is quite characteristic of a behavioral variant type of FTD. Now in the C picture and the D picture, we can see see asymmetric dilatation of the temporal horn of the lateral ventricular, which suggests significant atrophy in the inferior frontal, in the temporal and inferior frontal gyrus region. So this is mainly the language areas which are getting affected and which is seen as PPA. And similarly, we can also see the temporal pole atrophy, which is also seen in semantic variant of dementias. So this we have already covered, the Parkinson's disease dementia and dementia with Lewy bodies. And this is the typical fashion in which we can actually look at the course of dementias. So vascular dementia has a stepwise course, Alzheimer's disease has a progressive decline, and dementia with Lewy bodies has an alternate fluctuating kind of picture. Normal pressure hydrocephalus is another form of dementia, which is characterized by triad, which is known as the Adams-Hakims triad of urinary incontinence, gaze instability, followed by dementia. And the gait instability is known as gait apraxia, wherein they walk as if the feet is glued to the floor. So this also is a communicating hydrocephalus, and if detected early enough, you can actually do a shunt procedure which can reduce the CSF pressure and also improve the cognition as well. So this is the CT image. And CJD, we have discussed, is a rapidly progressive prion disorder, and it can actually result in a rapid deterioration in cognition. And EEG and MRI are classical in this particular illness. And 90% of the patients have myoclonus versus 10% in AD. So this is the MRI images, which shows that red arrows indicate the inverse hockey stick sign of because of hyperintensity of the basal ganglia, and the yellow arrow indicates the cortical ribbonning. So coming to the final summary of approach to dementia, you have to look for cognitive decline, associated problems with memory. And then you have to look into mood or behavioral problems such as apathy or irritability, loss of emotional control. If these are present, look for functioning, look for impairment in activities of daily living, how they are able to handle instrumental activities as well as activities of daily living. And if it is present, it is likely to be dementia. Now, if dementia is unlikely, you should exclude other mental health conditions. Then you have to evaluate for the cognitive impairment. Is it a gradual onset symptom, or it is a rapidly progressive symptom, or it is a long duration or short duration? Now you have to ask for abrupt onset or short duration. If it is a gradually progressive or slow insidious onset, you have to look for features of depression. If there is features of depression, you have to consider depression and treat it accordingly. If not, suspect dementia. If there is change in the sensorium and very acute onset, you have to consider delirium. Also, then final is to recognize once you recognize the syndrome, you have to also look for medical comorbidities, because there would be many medical comorbidities which would actually worsen the cognitive decline. So you have to look for, you have to do a detailed assessment, neurological and medical, and look into the nutritional status. If it is affected, you have, like B12 deficiency seen in majority of the patients, you have to supplement that. Do they have cardiovascular risk factors like hypertension, cholesterol, obesity, heart disease? Correction of that could actually reduce the cognitive burden. And the red flags which we have to look into are the rapid decline in function, younger than expected age of onset, if there are prominent fluctuations in cognitions, if there is acute or chronic high-risk exposure, if there is history of high-risk behavior, unexplained or unanticipated neurological findings, which is out of proportion to the cognitive deficits, and neurocognitive testing is incongruent with the clinical history. Clinical history would be different, but testing shows something else. In such case, we have to see what exactly is the problem, because this is an important red flag. So with this, I can start with some case vignettes. So there are only few case vignettes. So this is a 70-year-old female presenting with progressive memory.
When you say that we are going to have some case vignettes, you want people to, after telling the case, will you wait and then will people diagnose it, or what is it? No?
People can diagnose it. People can diagnose it if they can unmute and tell the diagnosis. It can be done.
Or write in the chat.
Or they can write in the chat, madam. Yes.
Yeah, yeah.
They'll not be able to unmute themselves. They're all force muted. They can write in the chat.
Write in the chat. Yeah.
So this is case 1. 70-year-old lady presents with progressive memory loss for past 2 years. She also complains of difficulty in naming objects and driving car and housekeeping, along with occasional wayfinding difficulty. For the past 1 month, she has difficulty in dressing, eating, gets agitated easily, and wanders around at night. So with this history, the MMSE scores has come to 15 out of 30. Neurological examination was normal, vision and hearing was normal. And then we embarked upon the investigations. The MRI suggested of bilateral medial temporal and parietal atrophy. So this is the case, and we can look into the likely diagnosis. We can actually, people who are able to make guess a diagnosis can actually put in the chat. So the clues are 70-year-old lady. So in the early age, in the late age, after 65 years of age, there's a progressive memory loss, and naming difficulty is there, and visuospatial difficulty is also there, and difficulty in ADLs is also there, as well as normal neurological examination and normal vision and hearing, with MRI, medial temporal and parietal atrophy being prominent.
Somebody has written some. Anup has written Alzheimer's dementia.
So the answer is correct. It is Alzheimer's dementia. And we'll go to the next case vignette. So it's a 76-year-old male. History of smoking is there, almost amounting to dependence pattern. He presented in OPD with complaints of progressive memory loss, emotional lability, gaze disturbance for past 5 months, and history of 3 episodes of cerebrovascular accidents in the past, worsening of cognition after each attack, and recent such attack was 7 months ago. So he has multiple comorbidities, substance use, especially smoking. He is a gentleman, and his history of hypertension, diabetes, and coronary artery disease, and 3 episodes of CVA in the past. And on examination, there are some deficits. There is increased tone in the limbs. Power is low in the right upper limb and lower limb on the grade 4+, and 3+ in the left side. So left side, there is some hemiparesis. Bilateral extensor plantar is also being seen. And the imaging shows these features, that is white matter changes, some lacunes in the T2 flare images, and in the diffusion weighted images, you can see a hyperintensity. So what would be the possible diagnosis?
I think Anup has again written.
Yeah, so this is a case of vascular dementia. And now coming to the case 3, 58-year-old gentleman who presented with 2-year history of progressive alteration in his social behavior. So social cognition was affected first, behavioral issues, history of social disinhibition, abusive language, euphoria, and food faddism. He started taking excessive carbohydrate-rich food and weight gain from past 1 year, and he was taken to a psychiatrist for his behavioral complaints. On examination, vitals are stable, but neurological examination revealed frontal release reflexes being present. MMSE was not bad. It was 24 out of 30. What could be the possible diagnosis?
Ramling has written frontotemporal dementia. Yeah.
So that is correct answer.
Yeah.
Now only 2 more vignettes. So case 4 is a 84-year-old gentleman who came with complaints of progressive decline in memory for past 8 months. He complained of reduced sleep and occasional nightmares and hand movements in deep sleep. This was noted by his wife. He occasionally by his this was noted by his children, and he occasionally sees his deceased wife. So he says that wife is there and talking to him, but she was actually not there when evaluated by the son. Was started on risperidone by the local doctor because of behavioral problems, following which he had significant rigidity, tremors, and salivary drooling. And on examination, his vitals were stable. There was significant rigidity of the limbs. He had slow stepping gait and bradykinesia. The MMSE was 21 out of 30. He also had deficits in visuospatial functioning. And now this is a very elderly person. What could be the possible diagnosis?
I think one of them has written DLB.
Yes, madam. So now coming to the last case vignette, the 65-year-old gentleman presented to the neurology OPD with complaints of gait disturbance for past 1 year. Because of gait, he was taken to neurology OPD. On history taking, the son complains that the father is having memory loss also for past 6 months and it is progressing. The patient also complained of urinary incontinence. Neurological examination was done, no focal deficits. However, they noted excessive slowness and increased processing speed. MMSE was 23 out of 30. So the clue is gait disturbance along with the patient's complaint of urinary incontinence and memory loss. So what would be the likely diagnosis?
I think quite a few people have written NPH.
Yes, madam. So that is the correct answer. So these would be my references and further readings for those of you. And I sincerely thank our patients and caregivers, as well as consultants in geriatric team, Professor Matthew Varghese, Professor P.T. Shivkumar, Dr. Preeti Sinha, and Professor Srikala Bharath Madam for helping and chairing this session, and my colleagues who are there in the geriatric team, as well as fellows and members of the psychosocial team in our geriatric psychiatry unit. I thank you all.
Yeah. Thank you, Thomas. That was quite a comprehensive one. If people have questions, they can start asking. The participants, I see that there are about 25 to 29 participants, and people can start asking questions to Thomas. I thought that I would start some of the initial discussion. When somebody is sitting in a geriatric clinic and people are mainly tuned to memory deficits and behavioral disturbances, then it is usually not that much difficult. to diagnose generally dementia. But what happens is when you go out into the community and when you see a younger person, especially coming with behavioral issues, the tendency is to look for, especially psychiatrists, to look for mental illness rather than actually dementia. So I remember we had a 30-year-old man who was diagnosed as schizophrenia and then started on medication. But over 1 month, we could make out that actually he had frontotemporal dementia because the behavioral issues became more and more clear, and slowly he was developing memory deficits. So that becomes the issue. Because when patients have cognitive deficits and then affective symptoms and then behavioral issues, they go to a neurologist. Usually when they are in India, mainly moderate and severe. But when they have behavioral issues, then affective issues and then cognitive issues, then they come to the psychiatrist. So because then the first port of parking becomes the psychiatrist. So that's the thing which we need to constantly, because dementia always has all these ABC, components of symptoms. And often we forget that who lands with a neurologist and who lands with a psychiatrist and why is it? Okay. So that is one thing. I'm just looking for questions, whether anybody has asked any questions. So far, no. Thomas, some of the things which I thought, whether you could show some light, and where, people like Swarna Alladi also have done some work is, whenever you look at somebody's clinical picture, you are also looking at, one is whether they have dementia, what is the stage of dementia, and are they having what symptoms, ABC symptoms, what is the predominant symptom, and then how their functionality is affected. That is, you talked about ADL, but what is very important is in a lot of conditions, I think the IADL becomes very important. So that is one thing. The second thing is the protective factors. What are the risk factors and the protective factors? Because you need to sort of talk with the family members about how do you see this person? What will be the prognosis and what will be the progression? Many a times people would like to know, and you look at what are all the things which can protect them, which are protective factors which are available, and what are the factors which actually, if somebody is diabetic, hypertensive, BMI is high, is not educated. So those are some of the things which we need to remember. I thought that we need to look at it. Okay, yeah. Rapidly progressing dementia, anything else to be considered if serology, thyroid function test, okay. Autoimmune has any role? I thought you talked about autoimmune in one sentence.
So autoimmune dementia is now actually one of the very hot topics because it is a rapidly progressive kind of disease. And people often tend to do serum autoantibodies. And these antibodies mainly targeted against the NMDA receptors, the VGKC receptors, and the GABA B receptors. So these are some of the receptors which are implicated in autoimmune encephalitis. However, the role of steroids, it all depends on a case-by-case kind of approach. So there are some cases, some studies to suggest that once the brain matter is significantly affected, the steroids do not have a role, and it would be more of a supportive and palliative care which would help. But there is another area of research which says that autoimmune panel is significantly important. But if there are other clues for malignancy, we have to look for paraneoplastic markers, which are actually very important, and they can actually detect malignancy before the malignancy manifests itself. So these are some areas I think Madam can add more about this.
How often do you see in your practice? Because I know that you have worked in neurology, you have worked in psychiatry, you are working in psychiatry now. So how often do you see, because in all my entire service, I have seen one NMDA encephalitis. So how often do you see autoimmune dementias?
Madam, actually it is not very common. It is very rare. However, now the number of testing is also increased. So many a times we do pick up NMDA receptor positivity, may not be significant positivity. So there would be elevated titers more than the borderline range. So there the controversy will come. But the thing is, because we are testing, we are looking forward and we are testing, we are not sure whether it is like an epiphenomena. We are not sure that whether it is like an incidental finding and coexist with this kind of degenerative dementias also. So that is one issue actually.
Yeah, somebody has asked about antidepressants, and Matthew has very clearly said that that will be covered in pharmacological and psychosocial management of dementia. So we are not going to. Some of the things, other things which I thought was when you're, especially since we are in India and we are also in a center where even people from the rural, suburban and rural areas come to us as a first line of contact. The tools which we use to assess them, to diagnose dementia, including HMSC, and I think you had very neatly put that how HMSC is derived from MMSC and looks very, very different, and how it is culturally very, fair.
Yes, ma'am.
And not loaded with things like who is the president of India or the prime minister of India and things like that, and including the copying, the visuospatial one, how it has been altered for the Indian thing. Even then, we have people who would have never held a pen or a pencil, even though they may be 7th standard educated. For a long time, they might not have held a pen or a pencil, paper pencil sort of a thing, and that noviceness makes them perform very poorly, and that becomes a very, very important issue. I think many of the people who are listening, so they need to know how, when you're in a geriatric clinic, how the approach and the diagnosis is very different from when you go into private practice or when you are working in a rural area or into the community. Even in an urban area, it becomes very, very different. And there is a lot of challenge for you to actually understand whether it is normal aging or less of familiarity with the tools, or whether the person really has dementia. It becomes a very, very difficult issue because not being familiar with paper pencil. So then how do you go on to diagnose dementia in a person who's not literate, who's not educated? So that becomes a very important question. And and we also know that these are the people, because we are in the LAMIC countries, we are the people who are going to have the maximum amount of increase in the number of people who are going to have dementia. And our approach and diagnosis to dementia need to be that sensitive to be able to address some of these factors in lower and middle income countries where the literacy rate is quite low. Yeah. Any questions about that, students? Questions about treatment should be covered more than in NMDA. I think we should see of thyroid or SLE even so, it is not so common, and the diagnosis is usually an association with high TSH or other autoimmune pattern. Yeah, we have had autoimmune encephalitis being presented, but in a case conference, I have treated one teacher actually for a long time, and it took us some time to make a diagnosis, and she had lots of behavioral issues. And yeah, I think I have shared this even earlier in one of the geriatric thing. It took us some time to diagnose, but once we diagnosed, we were able to work with her. But not that she improved significantly, but some of the behavioral issues came down with a lot of behavioral management. So that is something. About I do not know how often. There are two things which I thought you should mention because we are functioning in India. We are in India. One is the multilinguality, where Swarna Alladi has done a lot of work. And many of the Indians are multilingual, especially in an urban setup. People will know 1 or 2 languages. That's one thing. The second thing is the Alzheimer's versus vascular dementia. If you look at Manjari Tripathi work and other people, because we are the capital next to China now, diabetic capital of the world, and hypertension is the most common, comorbidity which we see in all, morbidity which we see in all elderly. So vascular dementia being as common as Alzheimer's dementia in India. These are some of the factors I thought in our approach to dementia in India, we should be focusing on. Because we think that vascular dementia is something which happens only in males, only in people who are slightly younger, not so. Because in our country, we have a huge number of people with hypertension, not treated or badly treated or irregularly treated. So, and the food habits not being that, because we have moved away from the rural type of eating to an urban type of eating with high carbohydrates, high sugar factor. I thought those are all some of the factors which we need to remember when we approach dementia in the LAMIC countries. Yeah. Somebody has, again, Matthew has written about infections, which is very true. I think, Thomas, would you like to comment on that? Herpes and possibly now COVID-19.
Yes. So there are a lot of literature on viral encephalitis, especially herpes. So herpes is notorious in the way that it is a virus which goes through the nasal route. So the medial temporal lobes get affected first because it penetrates to the cribriform plate of ethmoid. And the medial temporal lobe, which are the main stress center for memory, gets affected. Along with that, they will have other manifestations. Like they may have a period when there are delirious, there would be infection, there could be seizures. So these are some of the clues which will give a idea that it could be viral encephalitis. And typical MRI imaging and typical EEG changes. EEG will show what is known as biplex, will show that, or the FIRDA, which shows actually the rhythmic delta activity. There is significant slowing in these regions. And there is sequelae of viral encephalitis. I think being in NIMHANS, we would have seen multiple patients who come. They had developed viral encephalitis before, and maybe after 5 years or 6 years, they are developing sequelae secondary to the viral encephalitis, characterized by significant memory deficits, movement disorders like that. And also COVID-19 sequelae, like Sir rightly pointed out, there are a lot of literature which is coming, which is telling that COVID can affect the brain. It can cause strokes. It can cause, it can cause, encephalitis. It can cause meningitis. So there are meningoencephalitis. So multiple combinations are now coming up. And it also related to the blood coagulation factors. So if there is a hypocoagulable or a hypercoagulable state, like in DIC, there can be significant hypoperfusion to the brain, resulting in brain, the basal ganglia ischemia. So a lot of literature is coming up. COVID-19 arthritis by vasculitis by itself is a big topic.
Yeah. Two things, I think, because you started with, is this person born with the cognitive deficits? Yes, then you said that the person has IDD. Okay, look at the picture of somebody who's 30 years old, okay, and develops an encephalitis. Okay, or we have had 2 waves of encephalitis. One is when we had the very high HIV/AIDS. That was one thing. And then Japanese encephalitis, when adults were affected. When these two were there in a form of an endemic. Okay, so we have seen a lot of people having subsequently some sort of a cognitive deficits. So where would we, and we also see that in psychiatry, somebody under the influence of alcohol hangs himself or herself and then goes into hypoxia, comes with stable or even improving cognitive deficits. So I'm sure that one of the questions is, would you call them people with dementia, or would you call them just, post-encephalitic sequelae and then stop with deficits? So these are some of the questions. Should all the dementias be progressive? Then in which case the irreversible dementia is a redundant concept, or can dementias decline in the cognitive ability from the previous ability, and then there can be a stability or even a relearning can happen. So these are some of the concepts which we need to understand. What do we call them then? Okay, and of course, treatment, we will not talk about it, but conceptually, where do they go? It's because you have talked about stable encephalopathies.
Yes, madam. So most likely it should go when we actually address cognitive decline or try to approach cognitive decline. These are all causes of cognitive decline. Like the all etiologies which I had pointed out can be neurodegenerative, can be infective, can be due to autoimmune causes. So this is actually in the broad rubric of dementia as an umbrella term, we can tell that these are dementias. Now the thing is, this is mainly important, especially with respect to the disability benefits, the welfare methods which are actually required. So they may be asking whether the patient will progressively deteriorate or will he become stable, wherein he can do some of the ADLs. So these are some areas which we have to serially assess the patient. And I think a regular follow-up, at least over a period of the recommendation, the American Academy of Neurology gives is every 6 months you follow up these people, because some of them do tend to improve. Some of them do actually, their cognition worsens. And people who improve, usually they have found that vascular risk factors and people who had other hypoxia related injuries usually tend to improve. There is compensation of the other brain areas which because of neuroplasticity. Whereas there are neurodegenerative, like in Alzheimer's or frontotemporal dementia, we do not expect that kind of improvement. Rather, it will be a typical pattern, which were in the IADL followed by the ADL, and significant decline in the cognitive faculties happen. So that would be my take on it, madam. We do not have any particular terminology to describe that. But once you diagnose static encephalopathies, we are actually, we should be more proactive in actually finding out and rehabilitating the patient, because that can be actually helpful in reversing it to some extent.
Some of the things I thought you should, which we use in our geriatric clinic as an approach to diagnosis and approach to dementia, and because of the frequency of the higher prevalence of vascular dementia, is the Hutchinson's ischemic scale, which you mentioned, Addenbrooke's, and for all the dementias, you know, screening tools, which you, one among them is of course MoCA, which is very, very popular in the Western world. We don't use it somehow in our geriatric clinic. We mainly use the HMSC and other neuropsychological batteries. Okay, and then, you know, that what is very important is it's just not the screening tool of cognition, but also the ADL, you know, like the EZ. And IADL is very, very important, because look at not a lady who drives car and goes to a bank, but a lady who's a housewife, who's cooking at home, where the person, the son or the daughter-in-law says she no longer, she either puts salt more or in the place of salt puts sugar, but she is able to wear her sari and then navigate within the house and goes out with us, only with us. So we are able to, and she is socially appropriate. Only thing is she makes a lot of mistakes in the cooking and doesn't keep the kitchen as clean as she used to. So this is the complaint. If somebody comes to you, how would you diagnose dementia is something which we need to know, because we just cannot be thinking only about, can a person go to a bank and then, you know, can drive, can, you know, take a bus to see the daughter. We should be able to diagnose dementias even in the Indian context, where after some time people think that, oh, they are retired, they need not do anything.
Yes, ma'am.
So some of the things which are very important are the IADLs in their own setup. So this lady who puts sugar and salt and doesn't keep the kitchen clean, I would definitely suspect, because that becomes a part of her executive functioning of planning, you know, sequencing, decision making, adjusting the salt. All those, according to me, are part of her executive functions, which she's slowly losing.
Yes, ma'am. This is very, like you rightly pointed out, it should be tailor-made for each person. Everybody's cognitive functions may be different because it is contextual. And based on that, we may have to understand on person by person basis. And in this respect, The EC scale, which is used in geriatric clinic, is something which gives an idea into the everyday ability scale for Indian population. More, and also there is a IADL scale for elderly, which was actually developed by in Indian population by Dr. Madhuranath. So this also into.
Yeah, I think we should use it more often in geriatric, in our geriatric clinic. Probably, translate it and then, use it. IADL, we should, of Madhuranath, we should use it much more because it's a good scale. I have found it very useful in all the, whoever has done the thesis with me. So that's a good scale. Anything else? Matthew, anything which the approach and the diagnosis? What about the multilinguality, Thomas?
Yes, madam. So the most important work was actually done by Swarna madam, Dr. Swarna Alladi and Thomas Back from, I think, UK. So what they have looked into whether bilingualism or multilingualism is a protective factor for dementia. And they found that in a country like India, if you have, it actually is a suggestion for the cognitive reserve. So if you have the ability to, or you have learned multiple languages, it actually is kind of protective for from actually getting into a significant cognitive decline. And another interesting aspect which is noted with respect to language and dementia is the primary language is the last to go. That is, the mother tongue is the last to go. So if my mother tongue is Malayalam and I have learned English and I have learned Kannada, then the first language which will go from me would be Kannada and English, and the retained language would be the mother tongue. So this is one of the concepts, and their studies also have proved that almost concurred that the L1 language, which is the primary language, is retained till the last.
Some of the anecdotes which are being told during the Second World War, a lot of people from Poland migrated to America and to other countries, and then as children and teenagers, and they learned English. But when they developed dementia, the language which they spoke in, and there have been anecdotal things about, especially after the Second World War and when they became adults, many of them went back to Polish. So first to come is always the last to go. Somebody has asked a good question, Anup Ji. How is the fluctuating cognition in DLB differentiated from delirium?
Yes, ma'am. So in diffuse Lewy body disease, the cognition fluctuation is actually, there would be altered sensorium, and they will have associated symptoms like visual hallucination, rigidity, and RBD features, and prominent visual hallucinations along with the cognitive decline. So this is one differentiating factor. Again, with the time duration of delirium. So for people with DLBD, it may last for hours or days, and it may not go on for months together. Whereas in delirium, there can be chronic delirium, and there can be delirium on top of dementia also, which is known as beclouded dementia. In such cases, they will have the typical features of delirium, wherein significant loss of attention, distractibility, reduced sleep, and they will have prominent multimodal, especially visual hallucinations. So these are some of the features which are typically seen in delirium. And for any cause of delirium, we have to look at the cause. So when you treat the cause in a case of delirium, usually they improve. Whereas in DLBD, there could be associated cognition, a deficit in cognition, which would worsen. And again, the persons, even though has normal metabolic functions, would have a fluctuating cognition. So this is basically they are telling because of the alpha-synuclein deposition in the ascending reticular activating system or the brainstem region in patients with the Lewy body dementia.
But I think the cross-sectionally, Anup, it is quite difficult to differentiate. When you see a person, when you go as a, as a clinician and then look at that person at that moment, quite difficult to differentiate. It is only by the history and, a lot of other associated symptoms, you can then find out, not by just looking at a person that's saying that, okay, this delirium, this fluctuating consciousness is because of delirium or because of DLB. Very difficult to say that. Only by as a spotter or OSCE. Even in OSCE, they have to give you the background information for you to make a diagnosis. Otherwise, very difficult. Because right now, I am seeing a patient who has actually DLB, And many a times, I'm not able to say whether she is worsening because of some delirium, because of her urinary tract infection, or because it is her worsening of the DLB. So very difficult to find out. Yeah. Thank you for that question. That's a good question. Okay. And then the issue of multilingualism is quite complex and controversial. In the India education system, most Indians who go to school are mandatorily learning 2 languages and more than that. With the Hindi, it will become more, I think. Okay. Definitely. Considering neuroleptic sensitivity in DLB, how is the visual hallucination? Oh, difficulty only.
It is difficult.
Yeah.
But cholinesterase inhibitors are supposed to have good role in DLBD.
They don't help a lot. They are supposed to help, but they don't bring down the hallucinations very significantly. We still sometimes are pushed to use, despite sensitivity, we are pushed to use sometimes antipsychotics. But using anticholinesterase inhibitors are supposed to help, but they don't, do away with the hallucination. Yeah. So Matthew has clarified that one among the causes of delirium could be DLB. Could be anything, could be a stroke, could be anything. An acute stroke can produce delirium, hypothyroidism, fever, viral infection, any of those things could be. It is one among the causes that can produce, which is true. Yeah, DLB, yes, a lot of things in DLB are quite difficult to treat, which is true. Yeah, you have to have a lot of work with the relatives. Not all families are willing to work with us. That's the other biggest problem with us, with the dementia. That's why it becomes a very challenging condition rather than any other condition in this world. All right. Any last words? Matthew says that he has finished. Anybody else? Any of your colleagues? Any other thing? Otherwise, we can thank you for anybody else? Otherwise, I thank Thomas for a comprehensive review. So mainly, what is dementia, types of dementia, the severities of dementia, how each one of them looks at ICD-10 and DSM, looks at dementia. What are the tools we might use, and relevance of dementia in our country, and some of the case minutes. The case minutes were too typical. We don't see such cases in our clinic. That's where the whole challenge is. Okay. Thank you very much, Thomas, for an excellent presentation. And thank you, Matthew and PT and all the other people, Chetan, who are all involved in the geriatric clinic, for calling me to chair this session. And I hope it has been helpful to all of you. Thank you very much. Bye.
Thank you, ma'am. Thank you very much for chairing the session. Thank you, Dr. Thomas, for your excellent presentation as usual. And thank you, Matthew, sir, for being the support you are. The session is available in YouTube in our NIMHANS Indians YouTube channel. So kindly go and see not only this, also other sessions on geriatric psychiatry and other super specialties. We have all the videos over there. We have over 56 videos currently. So you can all watch the videos and gain knowledge. So thank you one and all. Meet you all next week with another session from geriatric psychiatry. Thank you.
Thank you. Bye.
We'll be ending the meeting for all now.
Yeah.